upside down.
Okay. Okay.
So
Start there, then go here.
good morning, SPF friends. Welcome to Tampa, and welcome to the 2024 SPF Annual Convention and Conference. We're so glad that you're joining us virtually. Normally we did this last year. It seemed to work well, so we're taking this shot again. We appreciate our team here that helps put this together. This is going to be a great conference. As you guys know, last year we talked about momentum. And as we ended that conference, we kicked off the Spastic Paraplegia Foundation Centers of Excellence Research Network. And one of the big things we'll be hearing about at this conference is the progress that group has made in our first year as we get ready to move into our second year. So a lot of good things happening. You guys help us get the word out about the SPF and all that we're doing, all that we continue to work toward doing in terms of finding treatments and cures. But we got a lot of information in these next 2 days. And again, we're so thankful that you've joined us virtually. And with me, this lady, all of you know, you've talked to her, you've worked with her, and of course I work with her every day. Norma Pruitt, who is our executive director and who has put together this program and this agenda. Norma, great job, but share with our folks your thoughts about this weekend.
Well, we are so excited that everyone is able to join us in person. But if you can't join us in person, this is the next best thing, right? We're all here to have a great time and enjoy each other socially, but we're also here to enjoy all the information that's there. And there is a lot of information. So I want you to take all that in. I want you to look at and listen to and research what these doctors and investigators and physicians are talking about. You got questions, write all of those questions out in an email. Send all that information to us. You've got all of our email addresses, and then we're going to try to compile all that information and at some point have a bigger, broader conversation about what did that mean? What did they say? And we want to make sure that everybody is all on the same page. So thank you all for joining us. I want to give a big shout out to those folks that have provided sponsorships to the conference. As you guys know, this is not a fundraiser. We're trying to cover the costs and be able to, meet whatever research proposals that we've received. And we've got a list of things to go over as far as the research proposals. But I cannot do it without all of our sponsors, all of the contributors and donators. So thank you so much for letting me sit here this morning and talk with you. And I'll be running around, so you may see me zip in on a live feed. So wave at me, and I'll come back to you sometime later while we're here. Thank you, Greg.
Nora makes a great point. We could not do this without the sponsors, and I think you can access those in our on our website, sp-foundation.org, or you may have gotten those in the email that Norma has sent you about the conference. But look at those and be aware of who those sponsors are. We could not do this without them. And one last point that Norma makes, it's important for you guys to remember. This annual conference is just part of the annual ongoing work of the foundation. We'll continue with information we learn here as we talk about future SPF talks,
yes.
as we talk about future emails that we do to you guys. So
e-blasts.
So take notes, and we will be talking to you about more about these issues in the near future and through this next year. We're getting about ready to get started. We'll kick things off in a few moments by welcoming folks here, and then our MC, Tim Krogan, will join us. Our first speaker this morning will be Dr. Hande Ozdendler, who's our keynote speaker. So we're looking forward to kicking this off. Hang with us, and we'll be back with you in just a few minutes. God bless you, and thank you for being with us.
Thank you, guys.
Are these open?
Good morning. It's great to see you here this morning. I hope you've had a good trip in and you're well rested to get started at 8 o'clock in the morning. And I know that we've got some folks still registering out there, so we're a few minutes late in getting started to try to give those folks an opportunity to get registered and get in here. But just so you know, we've got a little bit of padding in our timing this morning, knowing that it might take a moment to get things going. So we'll be back on schedule very quickly because there's a lot of information for you to hear, a lot of people for you to meet. We want to welcome you to the 2024 SPF Annual Conference. I'm Greg Pruitt, the president of SPF, and on behalf of our board, we want to thank you for being here. We're glad that you're here. There's so many. You know, I remember the first convention that I went to was in St. Louis in 2009. And you guys can probably remember, whether you're HSP or PLS, you can probably remember this stage in your dealing with your condition. It was 2009 and Norma was still working and she couldn't go with me. So I'm in St. Louis by myself, and in those days the conference was a Friday evening meal and speaker, and then all day Saturday. And so I get there and I get in my room and I get settled in, and it's time on Friday evening to go down and register. And so I go down the elevator and I walk off, and I don't know anyone there at all at this point. So I'm beginning to meet people, and we go through the process Friday night, and then Saturday we finish our main speaking, and down a hallway are some breakout sessions. And so I take off down the hall to go to a breakout session. Now, 2009, Greg thought that he walked normal, okay? So I go around the corner and I get to a turn in the hallway, and as I do, someone said, "We really want to thank you for being here, and how long have you been dealing with HSP?" And I kind of looked at him. I thought I was sneaking around here, you know. But there are different stages in our progressions and in our diseases. And at that very first conference, I met some people who are still friends today. I met some doctors and some researchers who are friends today that I try to follow and keep up with what they are doing. So if you're a first timer in particular, we want to welcome you. About 60% of you are first time attendees. And we hope that next year that figure will be less, because we hope more of you first timers come back for a second time and a third time. We hope that you find value in what you hear and what you learn, the professional researchers that you meet and hear from and get a chance to talk to, but also the friends that you meet here. Again, it's strange. I've seen a number of people already that I only see one time a year, but they feel so much like family because through the year we work and think and talk about the foundation, but more importantly about our personal lives and the things that we're dealing with. And all of us from time to time, I'm included in this, we have difficult days. There are days when I get really irritated that life is the way that it is. But as I do that, I look around me and I'm very thankful for so many blessings, so many opportunities, You know, if I had my choice like you, I would choose that I'd never had this. But I can tell you, I have met a lot of great people. I have a lot of great friends. And I hope that as we do this together and we support one another, that makes a meaningful lifetime difference. So I'm going to try to deal with it in that vein, and I want to encourage you to be as positive as you can, even on the tough days. The foundation, over the past few years, has worked to expand the number of people who are involved with the foundation, who know about the foundation. And let me say some things to you. Probably all of you who are here have done some of the things I'm going to mention, but if you have not become a member of the foundation through registering on our website, on our platform, we want you to do that. We need you to do that so that we can communicate with you about a lot of things during the year. I'll give you, for instance, last year was the first year we did the virtual feed that we do, and you'll see me and others back here at this setup interviewing folks and talking about things for our folks who couldn't be here but who registered to do this virtually. Norma and others have sent out probably half a dozen email blasts, had discussions on SPF Talks about the convention and about the fact that you could do this virtually. But just in the last 2 or 3 days, we've had a number of folks emailing us saying, didn't know we could do it virtually. How do we do that? How do we pay for it? And so we need folks to register. We need folks to look at those email blasts when you get them, when you can participate in an SPF Talk. Those are the ways we get information out to you about the important things going on that we want you to know about and we want you to be involved in, because this foundation is only as strong as we are all together. I want to stop at the moment and encourage you in your program. On page 3 is a large listing of sponsors. And we're so thankful. I'm not going to read those to you. They are in the program. But that sponsorship list is growing every year, and we appreciate them. Some of them will have booths out here where they'll talk to you about various topics and various things associated with the conference and what they're doing. So please stop and visit with them when you can. Thank them for being here. And anytime you get a chance to say thank you to any of these sponsors, we appreciate that because they are important to us. I want to recognize our board members who are in the room. Frank Davis. Frank, are you here? And I'm missing you. I can't find Frank. Frank is here. We had a board of directors meeting yesterday, and I know Frank is here. He may be working on someone, but Frank Davis, I'll try to introduce him again later. Jim Sheehan. Jim, raise your hand, please. Here's Jim. John Cobb. Thank you, John. Tina Krogan in the very back. Thank you, Tina. So these are your board members who are here, and some of our other board members are participating virtually. We, as a board, want to thank you. Our word for the past couple of years has been momentum. We as an organization trying to build more momentum toward those treatments and cures. You know, we talked about yesterday in our board meeting, and at the end of the day, we had a 2-hour session with our researchers saying, okay, here's where we are. How do we get to the next step? How do we get focused in our research? How do we get focused organizationally and with you and finding those treatments and cures that are so important? We had a great discussion with him, and if you were at last year's meeting, you recall that last year we kicked off the Spastic Paraplegia Foundation Centers of Excellence Research Network. And that's a group right now of 10 clinics across the country who are working together to do things consistently, to build platforms and databases that can be used to diagnose people quicker, because I hear stories from many of you about how long it took to get properly diagnosed. So we want to have ways to get people diagnosed more accurately, quicker. We want to have opportunities to be able to share that information collaterally among the researchers so that what one researcher is learning and doing, others know about. Because it's with that working together, that collaborativeness, that we hopefully find some treatments. And you're going to hear people talk about some of those things quicker from this podium this week. How we maybe are beginning to focus on more clinic-based things that result in some clinical trials and treatments to test some things about making our conditions better.
You're an important part of all that in a lot of ways. Dealing with your physicians and your researchers is important. But I want to also thank you at this point. For the past 3 years, this foundation, with your help and the help of so many others, has raised about $1.3 million to go toward research. And you probably know from the information that at this point, 97, 98% of that money goes directly to research. And that's important that we funnel in and we focus on the things that, what have we learned from the research we've done, and how can we take the next step toward a treatment or cure that makes your life. And if you've got HSP, as I do, and I'm SPG4, what does that mean? Well, 13 people in my family have had it. The worst part for me is my 36-year-old daughter has it. And beyond her, 5 grandchildren who have a 50% chance of having it. Those are the reasons that I still do what I do, and Norma does what she does with me with the foundation. We believe, we hope, and we're going to work to do all we can with you and with our board to find a day that we have a treatment that makes life better for us and for those who come after us. So I want to thank you for all that you do to help make that happen. The contributions that you make, the people you talk to about contributing, it all matters. Every penny adds up to a very important part of the process. But momentum has been a key word. We want to continue that momentum as we go forward in this meeting and in this year. A couple of other things you're going to hear about that maybe you haven't heard these kind of presentations before. We want you to know that your board is looking as broadly and as widely as we can, not just at research, but are there efforts out there to take prescription drugs, compounds, chemicals that might work for other medical problems that might work for some of us? There are organizations out there that are looking at those kind of process. Now, that's like research. It costs money. But we want you to know we're looking at those and whether we might make some progress in that regard. You're going to hear from a company today called RareBase. And that's what they do. We just want you to know that we're looking at those things and for you to understand some of those things. The young lady who'll be presenting and talking to you about RareBase is Natalie Downs. Another presenter you're going to hear today is from an organization called CPATH, a gentleman named Tom Hart. We all know that major dollars for research in our areas come from the National Institute of Health. We need to have the Federal Drug Administration involved. There are a number of Washington components. If we make it over the top, we're going to have their involvement, their help in many ways. So we're looking at organizations like CPATH who exist to help organizations like ours better network, better work with those networks that can help us reach those folks in places like Washington, D.C. So you're going to hear from Tom about our work in that area. So you're going to hear a wider range of discussions about the things your board is doing. We don't want that to be boring. We want it to be educational because we need for you to understand what we're trying to accomplish on your behalf. And we welcome your input. We appreciate your input all the time. You guys that were at our conference last year know that I'm a book reader, and I like to share sometimes things from books. And as I thought about this conference and where we are, I looked over at my bookcase and I saw this book that I read probably 15 or 20 years ago. It's just called Wooden. It's a book about John Wooden, the former basketball coach at UCLA. And if you're an old college basketball fan like I am, you know that he's probably the greatest college basketball coach that ever coached. Those of us who are from Kentucky thought for a while Calipari might be it, but he's gone to Arkansas, so we gave up. But anyway, John Wooden, a great coach, won 7 national championships in a row and 10 overall. And he was born in 1910 in Indiana, grew up in kind of a poor situation, but was focused and trained and worked hard all of his life. And as you all know, 10 national championships is quite a feat. But this book is an easy book to read, and it just has a lot of old stories, a lot of principles that John Wooden lived by. when we were in Pittsburgh, our theme was, and we did some video stuff about it, it's time. It's time. It's time for success in treatments. It's time for success in cures. It's time for us to grow more in that direction. Well, one story I want to tell you two real quickly. One in this book, in 1975, John Wooden won his last national championship. And being an old guy from Kentucky, I remember that year well because I was 16 years old, and John Wooden and the UCLA Bruins on semifinal night beat the University of Louisville. Well, if you're a UK alum and fan like I am, that was a great night. We were rooting for UCLA. But that meant the University of Kentucky now was going to play UCLA for the national title on Monday night. Well, John Wooden writes in this book that all of his years, when the game was over, he knew he had to head to a press conference, and he looked forward to talking about the game, meeting with his players. He looked forward to the post-game work that he did. But that evening after he beat the University of Louisville, as he walked off the floor for the first time ever, he didn't look forward to that. He dreaded that. And in the steps from the court to that press conference or to his dressing room, he made the decision, it's time. It's time for me to retire after tomorrow night's game. Now, the story is that he hadn't told anyone but his wife. His players didn't know, the media didn't know, but he made that decision on his own at one time based on the circumstances. That's where we are. It's time based on where we are, how we are growing, how research money is growing. It's time for us to take that next step toward finding those treatments and cures. And every one of you, every one of us is a very important part of that. You may be here saying, I'm here for the first time and I'm learning and I don't have a role. Yes, you do. You may be here and your disease may have progressed to the point that you feel like, I can't be very involved. I can't be helpful. I can't make a difference. Yes, you can. I want to read this to you. It's entitled, Why Teams Fail. I'm getting older in my eyes too. He writes, no matter how great your product, if your sales department doesn't produce, you won't get the results you want. Different departments must all function well for the company to succeed. Different individuals must also function well for the departments to succeed. It takes all doing their best. I told players at UCLA that we, as a team, are like a powerful car. Maybe a Bill Walton or Kareem Abdul-Jabbar or Michael Jordan is the big engine, but if one wheel is flat, we're going no place. And if we have brand new tires, but the lug nuts are missing, the wheels come off. What good is the powerful engine? It's no good at all. A lug nut may seem like a little thing, but it's not. There's a role that each and every one of us must play. We may aspire to what we consider to be a larger role or a more important role, but we cannot achieve that until we show that we are able to fulfill the role we are assigned. It's these little things that make the big things happen. So no matter what seat you sit in today, no matter your age, no matter where you're from, no matter where you are in the progression of this condition, or you may be a spouse or caretaker or supporter, whoever you are, wherever you are in this process, you are extremely important, and we need you, we need each other. So thank all of you for being here. I look forward to meeting as many of you as we can over the weekend, because when I leave here every year, well, we have some great new friends. So take time to meet everyone that you can, and we appreciate you being here. Now, I'm looking around the room. Tim Krogan, who most of you know, is our MC, and Tim does a great job. But Tim, anybody know where Tim is?
Hey, I'm coming. Give me a minute.
Would you get in here, Tim? Come on.
Look, man, I've been on this journey for the last half an hour to get all the way from the 6th floor down to this ballroom. I am on my way, but I'm taking it a little bit easy because I got me a little bit of potatoes in my pants, and I'm on my way to the stage. So everybody, just hang on. Hey, by the way, who put the stage all the way over there? I mean, come on. I'm getting there. Don't worry. Don't worry. We'll still be done by Sunday at midnight. Don't worry about it. I'm almost there. Uh-oh. Got a little sideways. And, of course, I come to the side of the stage with the stairs. Uh-oh. All righty, here we go. All righty, everybody. I made it. Just barely. As you can see, I'm wearing the latest fashion accessory, and they are called a potato pants. And these came from an idea from one of our members, Lori Renna Linton, and she lives in Austria, and it's a great story. We've got some information in the booklet about that. And this is really a great way for caregivers and members of families to understand what it's like for their family members to go through an upper motor neuron rare disease and kind of understand what they have to go through. My wife, Tina, has HSP SPF 7. I don't know what she's got. Now I screwed up all the adjectives, but who cares? But anyway, so she has SPG 7, and it's tough for her to move around and whatever, and this really is a way for me to understand what she's doing and what she feels. And I deal with her every day, and I love her, and it's our way to at least be compassionate and understanding of what she goes through during the day. This is also a way to do some fundraising. You guys can get together and do fundraisers with this concept. It's really kind of neat. We have some information about that in the booklet. Also, we have 4 pairs of these that we're going to have available for you to try on out in the lobby today. Okay? So anybody wants to try on a pair and feel the sensation I'm having right now, you're welcome to do that. So we're going to have those out there for you guys to deal with and run around with today. You know, this hotel is kind of done in a circle. Maybe we'll time you taking laps around the building, okay? So anyway, much ado about nothing there, but here we go. We do want to show you a quick little video that was produced with Lori Renna Linton, and it tells her story and about the potato pants. And what we want to do, I have to open my phone here for a quick second and read this intro. We want to have a special thanks to Daniel DeFabio. He's the person responsible for the documentary and helping to organize the Rare Advocacy Summit. And this documentary is with Global Genes and the Disorder Channel. Okay, here we go.
My nickname is Runner, a play on my last name, Renna, but mainly because I'm a pretty fast actual runner. I was diagnosed with hereditary spastic paraplegia, or HSP for short. My uncle's head. HSP is a communication problem. The muscles in the lower limbs get the signal to move either too late, too weakly, or not at all. Hence the difficulty in moving. It is also progressive. Let me give you a picture of what I mean. Here I am in 2014 at my house, attempting to run. This is a therapy clinic in 2018, walking with the help of hiking sticks. This is at my house with my physical therapist in 2021, testing my speed without hiking sticks. And this is not walking, but rather getting up from the ground in 2023. So you see, it gets worse over time to eventually being in a wheelchair, which I currently use whenever I'm outside of my house. I am no longer a runner, and there is currently no cure. I am physically disabled, but instead of my world diminishing with this diagnosis, it has only opened up possibilities. To be clear, I did not go from getting the diagnosis to immediately being okay with it. The way you thought your life was going to play out has been turned upside down. You imagine what you will no longer be able to do. But if you flip the script, It's not what you can no longer do. It's what you must now do differently and what you can do in addition. I co-created Potato Pants with Constanza, my friend and colleague. It is my answer to turning an idea into reality. In August of 2014, I went hiking with my 10-year-old daughter and her best friend. Along the way, I had to stop every few minutes. Mama, why do you keep stopping? Honestly, it's like walking with my pants full of potatoes. The next day, I told Constanza that I went hiking, that I had to stop often, and that I told the girls that it was like walking with my pants full of potatoes. She laughed and said, "Really? That's a great image. Let's figure out what we can do with that." We are both teachers at a school in Austria and have access to a huge community. Here is the Potato Pants idea that we pitched to them.
Wir werden ein Rennen veranstalten, bei dem wir Hosen mit Erdäpfel füllen, bis zu 10 Kilo, bei dem die Schülerinnen und Schüler, die Lehrer, die Eltern, die Politiker, alle, die kommen, um die Wette laufen werden, wobei es nicht ums Gewinnen geht, sondern darum, dass jeder einmal fühlen kann, wie das ist, wenn man im Alltag mit so schweren Beinen durchs Leben geht.
They loved it. And then they went to work. The sewing teacher made the pants. The phys ed teachers set up the racetrack. The French teacher volunteered to be the DJ. The parents made food. The head of the PTA organized the donation boxes. Students volunteered. And my student filmed the entire event, an excerpt of which you were about to see. That is how you harness the power of community to do big things. And that is how you turn an idea into reality. From that event, we raised 6,000 euros for research, but I thought the idea was so good that it needed to be revived. In 2016, my students took up the mantle. They wrote, filmed, and edited a movie to raise awareness of HSP. They created a huge stand at the Vienna Sports World, and they organized over 80 volunteers for the Vienna City Marathon. To date, Potato Pants has raised over 50,000 euros for research, and from our school alone, 15,000 euros. That is impressive, but just a drop in the bucket of what is needed. Potato Pants relates to the experience of HSPers. No one is saying that if you don't have HSP, you can ever know what it feels like. But waddling around in awkward, bulky, heavy pants where they're slow, off balance, and get tired quickly, will hopefully make people stop and think that it must be pretty tough going for HSPers. And with that awareness, develop empathy and appreciation and do things like fundraising. Some of the biggest insights come when they take the pants off, when they realize that HSPers are stuck in their potato pants permanently. My world has certainly been enhanced by this awareness of my body, of having to figure out how to do things differently. However, I have had this for 15 years. I got the lesson. I understand. It is now time to find a cure. The money we raise for Potato Pants will go specifically towards a project that is aimed at finding a cure. But that can only happen if we all work together. We need you. Together, we can do big things. Let's turn the idea of being cured into the reality of being cured.
Okay, everybody. Thank you. Thank you very much for enjoying that presentation and sort of understanding why I came in this way. And another thing is, if you notice, I sort of look like a zebra, don't I? Got a lot of zebra stripes on over the place. Well, that is sort of, we've got a nice little notation in our program on page 28 of why zebras. It's sort of the, what's the word we want to call it? The zebra is commonly known as the rare disease community as the mascot of rare diseases, hence the look of what I have today. So we want to tell you guys this is a really great idea, kind of fun, kind of nice to do, and you can learn and tell people all about what it's like to live daily with HSP or PLS. I got a couple of quick notes before we get on with the show. First of all, Dr. Fink is doing his gait assessment, so if you guys signed up for that, make sure you remember the times and where you have to go. He's over here in this corner of the ballroom space outside. Also, Dr. Fakari is doing his child assessments today and stuff, so make sure everybody gets with him at the right time. One big note, it says in your program, during lunch at 12 o'clock, it's supposed to be in the private dining area on the first floor. That's not where it's gonna be. It's gonna be in here, okay? It's a little too hard to lift and shift everybody to another space, and since we got everybody tucked in here, all the meals are gonna be done in the main ballroom. Okay, which it's going to be a little goofy. We got to be able to set the tables. And you guys who've been around a while have been through this before. It happens. The staff here is really good, and they'll be able to get us set up for lunch. Okay, the main thing is we just want to get going. We've got a lot of information for you. We're going to start off this morning with our keynote speaker, Dr. Ozdinler. So she's going to come up in a minute. We're going to set up her program's ready to go. Now she has to make an entrance like I just did. There she is. Here we go. Come on up. Oh, thank you very much. Thank you. You're all good to go.
Thank you so much. What a great conference, and I'm happy and honored to be here with you today. And I really like the idea of these potato pans because it gives an image on people, and then people can actually take it with them. And it's hard to talk to people if this hasn't touched them personally. And I think having images like this is very important for creating awareness. And for rare diseases, I think we have to create awareness to get everyone involved. But more important, or maybe equally important than awareness, is the science behind the research and how the research takes us forward. So I'm going to talk to you a little bit about, I don't know if I can move this, building treatments for upper motor neurons, and I'm going to team up with you. Yes, and I'll tell you next slide because I don't have my computer with me. I want to start by thanking everyone who made the research possible. And of course, the Spastic Paraplegia Foundation is one of the resources that we look up to when it comes to research. And our lab has been gifted by many other foundations, especially NIH as well and NINDS. So we thank them for the support that we receive, and it's a lot of grant writing, believe me. And the next slide, please. But more important than the money is actually the spirit behind the work. So we don't do research just to get the money. I think it is important that we help understand and bring a solution to an unmet need. And many people are suffering a condition that is so rare, and it came to them, and they don't know why, and they don't know how, and they don't know how to find a solution. But then when they come together, they create a community, and they create a momentum, and that makes the change. So I'm very thankful to Hank, and I don't know if he's watching us. He introduced me to this Spastic Paraplegia Foundation. I attended their meetings in Chicago, and I realized how passionate people were. And that passion is actually the fuel. And I'm very happy to be part of this community. So I thank all of you to be here and to create that momentum. I think you are the ones that makes us going every day. Next slide, please. So as you know, our overall goal is to have effective treatment strategies for upper motor neuron diseases. And I don't say HSP or PLS, I say upper motor neuron diseases. Because there are many diseases which originate when the upper motor neurons become vulnerable and progressively degenerate. And because we are already so rare, and then we divide among ourselves, I'm HSP, I'm PLS, I'm this mutation, that mutation, I think it defeats the purpose. I think we need to unite and say we are upper motor neuron diseases. And that is like an umbrella, starting point as an umbrella. So our overall goal is to have effective and long-term treatment strategies, right? But what are the roadblocks? Like, why can't we get there? What is the problem? There are actually numerous problems. One of them is the genetics of the disease, and the other one is the underlying mechanisms. Even though patients display similar clinical outcomes, the underlying cause which resulted in that clinical symptom may be different. And in that case, one drug may not work for everyone. And even though it's rare and then one drug doesn't cure everyone, so that's a problem. And then there were really no good preclinical screening platforms. Let's say there are companies out there who has a drug, but how will they test if this works in the upper motor neuron diseases, right? We did not really have preclinical screening methods. And then even if you start a clinical trial, what will be your biomarker? What will be the outcome measure? Whom are you going to include? So there are clinical trial readiness programs that were not ready. And I'm going to touch back on that because Dr. Mitsumoto has made immense progress in that area. But then once you realize what the problem is, then you can begin to bring solutions. So then the solutions could be that we generate knowledge about genetics and the mechanism of the disease. So we begin to understand the genetics of the disease, the mechanism of the disease. And then we can develop screening platforms for drug discovery. Then if it's so rare, maybe we can have gene therapy approaches for patients, especially with known mutations. And then maybe there could be drug repurposing, that we don't need to reinvent the wheel, that some drugs may actually work for some HSP or PLS patients. And we can identify new drugs, right? So I want to keep this as a thinking point throughout the symposium, because during the opening talk, you heard the idea that we are getting ready, we want therapies. I think we are at a point where we can begin to talk about how do we get there? Are we there yet? What needs to be done? What is the priority? Let's think about those things. Let's talk about those things. So next slide, please. All right, so let's talk about a little bit about the genetics of HSP and PLS. So HSP has, again, various types, and there are more than 80 genetics type of HSP, 80, imagine that. And then even though this is a rare disease, 80 different genetics. So next slide, please. Some of them could be autosomal dominant, which means even if you have one mutation, that is enough to cause the damage. And there are numerous genes, and I took them from the website of the foundation and also the clinicaltrials.gov HSP-PLS site. So you can go and search for those genes as well. I'm just giving a snapshot of some examples. But those are the mutations that are detected in HSP patients. And even if you have one copy of the mutation, that is strong enough to cause the disease. So whatever these genes are coding for, the proteins, imagine that. That protein must be so critically important for the function of the upper motor neuron that one protein not working can make the upper motor neuron decide to degenerate. So then the proteins that are coded by those genes are extremely important for the health and the function of the upper motor neurons. Next slide, please. And some of them could be autosomal recessive, which means you need to have 2 copies of the gene to be mutated. These are usually in the familial cases because the mother and the father may have the gene and they don't show phenotype because they're heterozygote, but then it may appear in the child. So there are numerous genes that are linked to HSP. Next slide, please. And also in PLS. PLS is actually a little bit different because they are also considering PLS within the spectrum of ALS, or the genes that are mutated in the PLS patients may not be the same as HSP patients, but some mutations that you see in the ALS patients are also in the PLS patients. So I chose this recent paper. Please go read that, and I think that's one of the most recent ones. So it gave a list of the mutations that are detected in the PLS patients. And I don't think we still understand the full spectrum of the genetics component of the disease. Maybe 10%, 15%, but there is a very large unknown sporadic component. But then what is the advantage of knowing the gene mutation, right? Why would we care about knowing the gene mutation? And what do those genes mean? Because if you look at them, one gene is a kinase, the other one is a actin skeleton protein, one of them is a receptor, they're all different proteins. How come mutations in different proteins lead to the same problem? So what do these genes mean? What do they do? And how come different gene mutations lead to the same disease? And if you know your mutation, how can this help you? Would this help you? And can there be personalized treatments because you know the mutation? And I want to pause here and tell you that knowing the mutation is actually critically important because we know from other diseases like SMA and recently ALS with the SOD1 mutations, there could be antisense oligonucleotides that are designed specifically for that mutation. And that could be personalized treatments or treatments just for that mutation. So the technology is actually there. There are antisense oligonucleotides, there are viruses, virus-mediated gene delivery, there are even small RNAs. So the technology is coming. And I think that's why knowing your gene mutation is very important. But of course, there are many questions. What is the mode of delivery? Is it toxic? Can we do clinical trials and so forth? But knowing the gene mutation is critically important. Next slide, please. All right, so let's say I told you that there are many genes that are related to the disease, right, in the HSP-PLS, and we call them the upper motor neuron diseases. And what do those genes tell us? We did an experiment trying to understand why different mutations in different genes all boil down to one clinical phenotype that is characterized as the upper motor neuron disease. We took all those genes that are mutated in patients, and we looked at their protein-protein interactions, and we identified their protein landscape, meaning with all their binding partners. Every gene that is mutated codes for a protein, and that protein binds to numerous other proteins to carry on a cellular function. So all these proteins that they bind to, we took them together as one group, and then we said, proteins, what do you do? What is your function? What's important for you? And they begin to tell us. They say, oh, the cytoarchitectural dynamics is very important for us. And we say, all right, axon transport and maintaining the long axon. And then they said lipid homeostasis is very important for us. And then they said, oh, if we have any neuroimmune modulation or if there's any attack, like an immune attack, we become very fragile. And especially for after these canonical pathways that are important for them, we said, all right, who interacts with whom? Where are you located? What do you boil down to? Are there any druggable targets? So we let those gene mutations speak to us about the disease mechanism. So I suggested you read this paper. The next slide, please. And then we went ahead and tried to understand, especially within spastin and alsin, and those are very unique genes that are mutated in upper motor neuron disease patients. And then we said, would the mutations help us understand disease mechanisms and also potential druggable targets? Now, what do I mean by that? Each gene has domains in them. And those domains are the regions where they interact with either different messenger RNAs or proteins or receptors, but they are different domains in each protein. And some patients have a mutation in one domain, some patients have a mutation in another domain. So when you have a mutation in one domain, I would imagine that whatever the protein is doing in that domain, the protein won't be able to do because there's a mutation. But other domains may still be working. So then we looked at the domain-specific interaction partner analysis. And by doing so, we made a heat map of the interaction domains in each partners in each domain, and then did canonical pathway analysis in these regions to see what is really important for that particular domain. So now it's not only the gene mutation, it's also where is your mutation? Which domain is your mutation in? Do you see we go very precise into the location? So when we do this for the alsin and spastin, we realize that they are very different. They are very different, but there are also some commonalities. Next slide, please. So when we looked for all those interactions and which canonical pathways are affected, then we said, all right, there may be some FDA drugs out there which have been either approved or in clinical trials, and their mechanism of action is particularly to mitigate or to improve that problem, like that canonical pathway. We searched, and we found many. So we found many FDA-approved drugs either or approved or still in clinical trial, and that are actually working on distinct canonical pathways that we identified based on our protein interaction domains for the alsin and spastin. Then we said, okay, is there any compound out there that may work for alsin and spastin based on the canonical pathways that are affected? And we found three, SMI71, and hopefully we'll be able to do research on that one. And there are two more, and they seem to be acting on the canonical pathways that are affected by the mutations in the alsin and spastin. So why do I tell you all this? I tell you because when we know the mutations in the gene, we can begin to understand what is the mechanism of the disease, what is the underlying cause of the disease, and also, are there any potential druggable targets, and are there any drugs that have been approved using that mechanism of action, using that specific target. That, I think, opens the doors for repurposing of drugs. Maybe we don't need to reinvent the wheel. Maybe there is a potential out there. Maybe the drug is already out there that we don't know which one to try on the HSP and PLS patients. So that's why the mutations, gene mutations, are extremely important, because they begin to tell us about the disease mechanism, and they begin to tell us potential druggable targets and potential compounds to test. Okay, next slide, please. All right, so this summarizes what I just said. It's very important to know the gene mutation. So if there is a way that you can understand your genetic cause, please do, because it tells us about the mechanism and targets, druggable targets, and so forth. Next, please. So the other advantage of knowing your mutation, and your disease is a rare disease, I want to bring this paper to your attention, and our friend Darius is also an author on that paper, is to develop gene therapy approaches for patients with a known mutation. I mean, that is a very new concept, but it's not out of reach. Because if you know your mutation, if you know how this mutation causes the disease, and I told you with the mechanistic insights that we bring, then you can actually develop AAV-mediated gene delivery approaches specifically for those patients who have that particular mutation. And I think this is a seminal paper along that direction, that if you know the mutation, you can have the virus delivered, and this was an intrathecal delivery, and that they used a APA for M1, and that's one of the genes also related to the disease. And they have seen some improvement in the preclinical animal models. So that will also bring us to the importance of having animal models, importance of preclinical studies. But this is, I think, the way forward, the gene therapy approaches. Next slide, please. So this is one of our work that we actually published in Nature Gene Therapy, and then they made the cover of our publication, because they really thought that this was important. And the reason it was important was because, especially for patients who don't know their mutation, you know, there are many of patients out there who don't know their mutation. For sporadic cases, can we develop gene therapy approaches? That's what we're trying to work on, because we want to find a protein that is so critically important for the health of upper motor neurons, regardless of which mutation they have. So we found a gene, the UCHL1 gene, is very important for the health of upper motor neurons, and we developed AAV-mediated gene delivery approaches to the diseased upper motor neurons, and we used SOD1 and TDP. Those are very unrelated and different underlying causes, and even in those two different spectrums of the cause, we have seen the same level of improvement. So now we have patent protection on this, and we are looking for drug companies to team up with, and hopefully we can move this into clinical trials. Next, please. All right, so now knowing the mutation is important because there could be AAV-mediated gene delivery approaches in therapies, either personalized medicine, or we can target genes and proteins that are critically important for the health of upper motor neurons broadly, and develop treatments more for the sporadic patients. These studies were not present 2-3 years ago. This is very new development, and I think this is where the field is going. Because the disease is so rare, it's very hard for us to do normal clinical trials with like 200 patients, 300 patients, phase 2, phase 3. I mean, that is very hard for the rare diseases. I think this personalized medicine approach is the way forward. Next slide, please. All right, so let's get back to our first slide. What were the roadblocks? The genetics and mechanism. I think we are beginning to understand the genetics of it, and then there are GWAS studies, whole genome sequencing. So we understand the genetics of the disease better, and we begin to understand the mechanism of the disease better, thanks to the genetics and thanks to some of the mouse models. And then potential solution could be that gene therapy approach for known mutations, or even for sporadic. So the gene therapy could be a potential solution. Next slide, please. All right, so one of the roadblocks, as you can remember, is how do we develop the pre-screening platforms? Because let's say people have some compounds, and some compounds go off the market, or their time has expired. Now they want to repurpose the drug. They want to know if it also works in a different patient population, but they need some pre-screening platforms. So now we step in, and our lab was actually the first lab to make a reporter line for upper motor neurons. So after we made this reporter line, NIH actually gave us $2.5 million to investigate this even more, because this was the first time that it was a cell type specific reporter line in the motor cortex. So as I told you that UCHL1 was very important for the upper motor neurons, so I took the UCHL1 promoter and I cloned the GFP gene under the control of the UCHL1 promoter, and by doing this, we created the transgenic line in which the upper motor neurons became fluorescent. So next slide, please. When we create this mouse model, the question is, which mouse model are we going to cross it with? Which one is the good animal model for HSP or PLS? We must thank Dr. Bass, and I don't know if he's in the room. Dr. Bass, are you here? But we must thank Dr. Bass for generating these mouse models. And thanks to him, we actually have very good spastin mouse models. And in collaboration with him, next slide, please. We crossed our mouse model with the spastin model to be able to make reporter lines of upper motor neurons in which the upper motor neurons are diseased, but they also express GFP. You can imagine the power in that, because the cells are in the culture, and when you add the drug, you can actually watch how the fluorescent neuron is behaving. So this creates a platform for drug screening, and we actually received a DoD grant to build this further, and we are now crossing them with the spastin mice to be able to have a drug discovery platform and help companies investigate whether their compound of interest would also have a utility within the context of upper motor neuron diseases. Next slide, please. So we are developing large-scale imaging and mathematical algorithms to be able to detect the branching arborization of these disease neurons and their response to drug treatment. So that's why this is semi-high throughput, because that's what the drug companies require. So we are getting there, and I think that we will be able to build a platform for drug discovery. Next slide, please. All right, so now lack of preclinical screening, check. I think that we are building that, and that would open the doors for repurposing and also drug discovery. Next slide, please. All right, but when we talk about drug discovery, I don't want you to think that it's so easy. There are so many challenges associated with drug discovery. So, for example, which compound, which drug are we going to test? And we need to know the cellular problems, the mechanism of action. We need to identify the target. Is there a good preclinical data? Whom are we going to include in the study, in the clinical trial? How will we know if the drug worked? What is the efficacy? And is it really doing what it is supposed to be doing? And how will we measure improvement in patient, like the pharmacokinetic biomarkers? This target engagement and pharmacokinetic biomarkers are really very tough questions, because if the companies don't feel comfortable that they can assess these quantitatively and reproducibly, they don't spend millions of dollars. They say, all right, do your homework, come back again. Because I need to know, will I know that it is doing what it is supposed to be doing? So this is target engagement biomarkers. So there are many challenges for the drug discovery. But then, there are ways to overcome them. Next slide, please. So I want to tell you our collaboration with Dr. Silverman. And Dr. Silverman is the inventor of Lyrica. And he identified a compound which we call NU9. And because we know that the upper motor neurons degenerate because of protein aggregation, mitochondrial problems, ER stress, cytoarchitectural dynamic problems, so we identified the problems. We know the target. And now he had a compound which did not have toxicity, had good pharmacokinetic properties. We investigated whether his compound would also improve the health of diseased upper motor neurons using those targets that we identified. And we published this paper, and I'm sure, is there anyone in the room who hasn't heard about NU9? Can you raise your hand? Have you not heard about NU9? You haven't heard? You haven't heard? A couple people have not heard about NU9. So NU9 is the first compound that is reported and published to improve the health of diseased upper motor neurons. And it made a big splash, it made a big news, because so far there was no compound, no drug that improved the health of upper motor neurons. And people were always working on the spinal component of motor neuron diseases. So NU9 was discovered as the first compound to improve the health of the upper motor neurons. So we think that's very important for the upper motor neuron field. And next slide, please. We realized that the upper motor neurons suffer from multiple problems. Protein aggregation, mitochondrial problems, problems with endoplasmic reticulum ER, that's where the proteins are made, and problems with their axon transport, problems with their apical dendrites. And with NU9 treatment, we were able to overcome all these 4 challenges at the same time. So to our knowledge, there is also no such compound that can overcome 4 different problems all at the same time. That's why we thought that it was very powerful, because compounds usually do just one thing. When you go for drug treatments or drug therapies, they say, what is the mechanism of action? Where does it bind to? They expect the drug to do one thing. But here, this compound seems to be doing 4 things, and all those 4 things are important for the health of the diseased upper motor neurons. Next slide, please. So then Dr. Silverman actually formed the company, Akava Therapeutics, and there may be a little insert in your bag about Akava Therapeutics. So the good news is, for the first time, now there is a drug company out there, and you can look at their logo, that they actually work on the upper motor neurons. Next slide, please. Yes, here in their logo, they say, our area of interest is the primary lateral sclerosis and inherited spastic paraplegia. And here's the QR code, you can get more information. But previously, there was no such company. But at least there is one drug company right now who is focused on the upper motor neuron diseases, and who also has a compound that improves the health of the upper motor neurons within the context of misfolded SOD1 and TDP. So that's why, the next slide, please. The question is, would NU9 also improve the health of the diseased motor neurons in HSP and PLS, right? So I'm thankful to the Spastic Paraplegia Foundation for supporting our research, and I'm gonna show you 2 videos. And the first one is actually a corticospinal motor neuron taken from the spastin mice and no treatment, and the dots that you see are the mitochondria. Can you please play the video? And keep an eye on the dots. Is the video working? Can you click one more time? Oh, it's working. Okay, good. Keep an eye on the dots. You will see that most of them are not working. Maybe there are a couple that are making a little move. Because in the spastin mice, the movement of mitochondria is affected. The axonal transport is a major problem. And then this is a 5-minute video. It's a short video. But here, this is actually in the spastin mice, we added NU9 to the tissue culture medium. Again, this is a 5-minute video. You can show it the video again. So there is improvement in the transport. Do you see it? But of course, please take these data with a grain of salt because we have to repeat them multiple times. We have to quantify them blindly, this, that, you know. But these are some very encouraging studies that we have done in the lab, and I wanted to share with you. Next slide, please. Yes, so there are some quantifications for the organelle transport, 18 hours in vitro or 4 days in vitro. With NU9 treatment, it seems to be that it is improving both in the spastin and in the G mice. And again, these need to be repeated multiple more times. Next slide, please. So for this figure, I really want to thank the Cure SPG4 Foundation. And they are two great mothers and trying to help their children. And they gave us support to investigate within the context of, again, SPG4 and NU9 in vivo. So we know that there are corticospinal tract defects within the spastin mice. And this area on the left is taken from the corticospinal tract. And you can see that these are coronal sections, so the axon bundles are coming towards you. That you know there is disintegration and they are disorderly, but with NU9 treatment, and we did 100 days, 100 milligram per kilogram, we did not see that anymore. So again, there seems to be an improvement, and we need to repeat those studies, but it was encouraging for us that it may be doing something. But again, it's very early and we have to repeat some more. Next slide, please. So the other thing is, when we have the spastin GFP mice, we can begin to understand what is the disease mechanism in those neurons. And the spastin mice crossed with the UCHL1 mice, the upper motor neurons are GFP. So because they are GFP, we can actually do fluorescence-activated cell sorting. That means we can isolate these motor neurons as a pure neuron population, and when we isolate them, we can do proteomics and metabolomics and lipidomics and all these omics studies and RNA-seq gene expression analysis to ask them specifically, what made you upset? Why are you showing signs of vulnerability while your neighbors are relatively healthy? What happened? And they begin to tell you. So next slide, please. Next slide, please. So with these proteomics and RNA-seq experiments, we begin to understand what is really happening in these disease neurons, and that also helps us develop the druggable targets and what is it that we can go after for the spastin mutation. Next slide, please. All right. So I think the problem with the drug discovery is that they're trying to solve all problems with one solution. They think we're going to find a drug, and that drug is going to cure everyone. So to me, this is waiting for Godot. Godot is not going to come. That's not going to happen because everybody is different. And we have to develop the cell-based and mechanism-focused drug discovery. We need to learn directly from those cells and ask those cells, why are you diseased? What happened? What made you upset? And then when they speak to us, this is my problem, that's what's happening, then we can say, oh, really? There's a drug out there FDA approved with the same mechanism. Or if that's your problem, let me just fix that problem. And it may be that it may be different problems for different people, and we may have personalized medicine approaches, and we may have a mechanism-focused drug discovery. So that's how we are moving forward. Next slide, please. All right, so then we again investigate the impact of NU9 on diseased upper motor neurons. This is something that we have to do because the timing is very important. If we can have a clinical trial for upper motor neurons, is it possible to include HSP-PLS patients? Can this be a basket trial? What is the biomarker for HSP-PLS patients? How will we know that the drug is engaged within the HSP and PLS community? What will be the outcome measures for them? So those are the critical questions that we have to answer. But I must say that, Dr. Matsumoto especially is doing an amazing job with the PLS natural history study, getting ready for clinical trials, and also the Center of Excellences that the foundation has supported, and they are getting ready for the clinical trial readiness. They really want clinical trials to be initiated. And that's very important and timely because as our research evolves in the identification of drugs, and we are developing biomarkers and pharmacokinetic biomarkers, then we can actually begin to work together and make this a reality. And I think all stars are aligning with the research and with the clinics that within a short period of time, we may actually bring those two components together. Next slide, please. All right. So then, biomarkers, outcome measures, those are coming with numerous people actually are doing biomarker studies, and we have the DoD grant working together with our colleagues at Harvard and Johns Hopkins. And I also talked about the drug repurposing because now that we have the preclinical screening and maybe the identification of new drugs, and we might have identified NU9 as a new drug. And I think we have touched upon most of the problems, roadblocks, and the potential solutions. Next slide, please. This brings me to the neuron connectivity. And you can see the artwork here. That's one of my photo arts. And I think this brings the idea of the connectome. And even though each one of us seem to be different, we are all connected in a different way. And neurons in our brain are also connected together to function. So if we want effective treatment strategies and effective functional treatment strategies, we need to connect. And that's why I generated this artwork, especially for this event, because I think the essence is that we connect. And once we connect, all problems will be resolved. Because every problem has its own solution within the connectome. So next slide, please. And I think now we are beginning to understand the underlying causes of the disease. We are developing preclinical drug discovery platforms using upper motor neurons and using their health as an outcome measure. We are developing gene therapy approaches. NU9 is a new compound which improves the health of upper motor neurons. There's a drug company out there focusing on upper motor neuron diseases, and if you want to learn more about the company, please come find me. I am the head of the scientific advisory board, and we are identifying new biomarkers and inclusion criteria. So we did not have a company before, we didn't have a compound before, we didn't have gene therapies before, we didn't understand the disease mechanisms before. The science is now exponentially growing. And what we have come to know within the past 2-3 years is more than what we have come to know in the past 50 years. So it is exponentially growing, and that's the time that we need the momentum. That's the time that we need this connectome. That's the time that each one of you become the spokesperson of the upper motor neurons. Because upper motor neurons are the spokesperson of the brain, but now it's our time to be the spokesperson for the upper motor neurons. And next slide, please. And I think there's a bright future ahead once we do this. And you can find my email there, my Twitter, Facebook, social media, internet, this, all my connections. Please, let's get connected. And there was a hat here, yes. So please wear that hat, take a photograph, share it with your friends, and let the voice and the awareness spread, because there are many people who are in this room, but there are many, many more people who are not in this room. And I think we need to connect everyone, and then we need to get the word out to as many people as possible. People need to understand that the brain matters, the upper motor neurons matter, and that if we work together, and we can actually bring a change to the field. So next slide, please. Thank you again for your attention, and I'm ready to take any questions.
Okay, guys, if you want to ask a question, first of all, we've got a couple of microphones out here in the middle of the room. So if you can make your way over here to ask them, or you can raise your hand and I can find you. Oh, I love this part. Crickets. This is
Yeah.
great. No, there's one. And of course it's way over there. Okay, I'm on my way. Hey, by the
then-
way, I slimmed down during the presentation and I can cover the distance a little bit faster.
So
But I
by
have-
the way, this artwork will be on auction tomorrow night at dinner. So please be generous and let the artwork help the science move forward.
Okay, here's our first question.
Thank you, thank you. So in looking at this flyer that Akava Therapeutics, is that the name of the company?
Akava,
That they're developing AKV9, is that the same as
Yes, it
MU9?
is the same. Yes,
That's, okay.
yes. Because when the company licensed it, they changed the name to AKV9, but we as researchers, we still work on the science aspect of NU9. We don't work with AKV9, we work with NU9. But the company is doing the toxicology studies, getting ready for clinical trials, but we still need to understand the mechanism of action. We need to understand the biomarkers, like the science portion, we still continue doing in our lab.
Okay, I got another question right over here.
I was late, so you may have already said this, but my son just got married, and he and his wife are concerned if their child will have this. My understanding when I was diagnosed in 2017 was that both parents, or both, two people had to have a gene. Is that correct?
It depends on the gene, because some genes are dominant. If you have one copy, that you may have the disease. But if it's autosomal recessive, then two parents must have the. It depends on the gene. You remember the slides that I showed you? Not all genes have the same penetrance, and it depends on the gene.
Okay, I'm going to take
Yes,
one more
yes.
from this side of the room,
Yes.
and then I'm going way over there. Oh, we got that. Norma, you got one over there? Here we go.
Yes, Dr. Bass.
Dr. Osdendler?
Oh, really? Okay.
Question, has phase 1 trial started with the NU9?
No, unfortunately not. So let me tell you what happened. After we made our discovery, the company licensed it, and we prepared our IND application to FDA. It was more than 3,600 page document, and I signed it, and it was like 1,200 pages that I prepared. And then they told us that it usually takes about 5-6 months for FDA to review, and about 80% of the cases, they get rejection. We got approval in 2 months. Can you imagine? So now we got FDA approval to start phase 1. And I thought, when we have FDA approval to start phase 1, everyone is going to pour money on us and we'll just do it. And that didn't happen. So we're still trying to raise funds, and phase 1 studies became even more expensive. The only limiting factor right now is the finance. We have the FDA approval, we're ready to go phase 1, and it's tough. Because, scientifically, we have done everything that we could. And it's now, the funny thing is, my father was a businessman, and I was like the rebel artist and scientist, and he would tell me, at the end of the day, everything comes down to money. And I was saying, no, Dad, it's the science, it's the humanity, it's the arts, blah, blah, blah. And he says, everything comes down. And now, he's right. Everything comes down to money, and it's not my domain. And I hope that there will be people who makes a donation to move this forward, and we're raising funds.
Estimation on how long phase 1 will last?
Yes, phase one will be on. Our scientific advisory board is actually, if you check the website, you will see Dr. Matsumoto is also there, and I'm very, very happy. We decided to include phase 1 only with healthy volunteers for a very good reason, because if we included ALS patients in the phase 1 clinical trial, then this was supposed to be only ALS clinical trial. But we said, let's have our clinical trial with healthy volunteers, so that we have the clinical trial as a baseline, phase 1 as a baseline. Then if you want to go HSP route, PLS route, ALS route, Alzheimer's route, FTD ALS route, other neurodegenerative diseases, you will have a baseline for healthy volunteers, and we can expand. So that's why our phase 1 clinical trials, we even know the site, we even know the trial design, everything is known. It's going to be healthy volunteers and single ascending dose, multiple ascending dose, and it's going to be 6 months study. And we hope with the recruitment, analysis, that, it's going to be 9 months to a year for the reports to be written and so forth. So that's why that 1 year is critically important for us to understand the biomarker, the studies for other diseases, so that when we get the results from phase 1, we can then begin to formulate how we're going to do phase 2.
Last question. How much money do you need to go forward?
It all changes with the economy. I don't know. Today it was last 3 million. Now it's 5 million. I think the earlier the better. I don't know that. I'm not a money person. I don't know, but we all know that we need support. So let me go back to Dr. Buss, please.
Here we go.
Hi, I have a technical question.
Sure.
With the work that you did with the SPG4 mouse,
Yes.
how old was the mouse to see that much degeneration? And when you introduced the NU9, was it after the degeneration had occurred or prior to? In other words, does the drug prevent the degeneration or does it reverse it?
Yeah, so this is a very good question. And by the way, if you don't know Dr. Buss, please know him. He is an amazing scientist, and he generated one of the best models for the HSV. So I'm very thankful to him, and I'm also very thankful that he shared his very precious mouse models with us. And we do our work in collaboration with him. So the question that he asks is about the timing. When do we apply NU9? That's very important. For tissue culture experiments, we need to put them in culture. And for those culture experiments, they need to be early postnatal, which means like they are P1, P2, P3. So they're like little itsy bitsy. They don't have any signs of disease. But we study the cell, the neuron. And imagine that even at that age, P2, P3, there are problems in their axon transport as early as that. So we put them in culture, we let them grow for 6, 7, 8 hours, and then we add NU9 and different doses, 10 nanomolar, 100 nanomolar, 500 nanomolar, and things like that. And then we let them grow for about, 6, 8, that was the bar graphs, different times, and then we make the movies. So that's for the tissue culture, they are very early. For the postnatal, that when we applied NU9 100 days, 100 milligram per kilogram, that we started when they were P90. And I think P90 is about the time, based on your papers, that they are pre-symptomatic. It's not very, very early in the disease, but it's not also very late in the disease. And we give them more than 60 days. And we can discuss.
So the images that you showed comparing the dramatic degeneration without the drug and the vastly different effect with the drug,
yes,
that was when the animal was what, about a year old? Or
I don't know, it's not 3-year-old, but that was towards the end stage. I think, yeah, you're right, because 180, 200 said they're about a year old.
Thank you.
So, but they were aged mice. They were not like early age mice, because we wanted to see first at the very, very dramatic phase. If we see anything, then we can go back. But if we don't see anything, even at the very end stage, then we say, you know what, this is not doing anything. So that's why we wanted to look first at the stage where the difference is very dramatic.
Hande, one last question.
Sure.
Were you able, in your histology, to see any other neuronal cell types? In other words, does that drastic degeneration that you see, is that only in the corticospinal motor neurons, or is that in other sorts of neurons as well?
That's also another very good question. So we have cellular molecular markers to distinguish corticospinal motor neurons, like let's say CTIP2, FESF, there are some markers that are expressed in corticospinal motor neurons. But because this circuitry, the connectome, is so complex in the motor cortex that these upper motor neurons receive input from many neurons. And there are thalamocortical neurons, callosal projection neurons, interneurons, and so forth, there are also molecular markers that are expressed specifically in those cells. So initially, we did our analysis on the upper motor neurons, but we have not done detailed analysis on other cell types. And what I haven't shown here, maybe next time I will talk about it, we also begin to do electrophysiological analysis to look for the functional connectivity of upper motor neurons. And I think that's very important because it seems as if the interneuron population has an impact on the upper motor neuron function, because we see cortical hyperexcitation early and then followed by hypoexcitation, and that means that the interneuron circuitry may be involved. And we looked at astrogliosis, macrogliosis, and large pyramidal neurons, and Kalbinden neurons, reticulin maybe for the interneurons, but not extensive studies on their loss or on their degeneration.
We've got a question right down here in the front, straight in front of you.
Sure. Yes.
Thank you for your presentation. I do have a question. I'm not exactly sure how to ask it, but I'm going to give it a shot. So for people that have had the disease for a while and have potentially significant, neuron damage, say this compound works and it helps, fixing the damage and like the neuron grows again. Is there, do we really understand the mechanism enough, or how these neurons are being damaged enough in each type of mutation to try and understand if there is say scar tissue that could get in the way of the, say we fix the neuron, there could be other things that could be potentially getting in the way of these neurons making the connections that they need to again. Speaking very loosely and in a basic way, but the question is around that other step outside of fixing the neuron itself, like the ability for the neuron to do what it's supposed to do. Could there be other things that could be getting in the way, such as scar tissue and things of that nature for people that are fairly advanced in their disease?
So if I understand your question correctly, and that's a very good question actually. So we answer that in two ways. When we define a problem, we ask this question: is it intrinsic or is it extrinsic? For intrinsic, we mean the problems that occur inside the neuron. That happens with their gene expression, with the way that they make the protein. We know what's happening inside their kitchen, in the cell, intrinsic. And there are extrinsic factors that are not dependent on them, but on their neighborhood, on their environment, on their, the interneurons not inhibiting them, and inhibitor neuron not inhibiting them, then they are excited. Or let's say they depend the axon, right? But then axon is attracted. How about other axons? How about the highway? If the highway is full of pots, it doesn't matter how good your car is, the highway is broken, right? So what is the extrinsic factors? So to understand this in extrinsic factors is very hard because there are multiple players in that, right? So in our lab, for the extrinsic factors, we focus mainly on the neuronal circuitry in the electrical sense, inhibitor neurons, excitatory neurons, and how they communicate with each other using electrophysiology. I did not show it, maybe I should have. And then the other extrinsic factor that we look for are the neuroimmune modulations, because there are those cells, astrocytes, microglia, that have an impact on the motor neuron function. And we have reporter lines of MCP1 and CCR2, and we double-cross them. We have triple transgenic mice to begin to understand how these neuroimmune cells contribute from the periphery to the central, to the function of the neuron. So we don't really focus on the track, the highway, if there are any potholes on the highway, but we are mainly considering the neighborhood in the cortex, how that is telling them, you can do this, go for it, I'm here with you. Or they say, oh, you can't do that. I know you can't do that. Then those are these communications that we have to improve. So we're looking for the intrinsic factors as well.
Okay.
I'm sorry, we're going to move on to another
Dr.
question over
Austin.
here, and then we're going to come here. We're going to finish up because we've got to keep moving. Okay, great question. Go.
Thank you for your presentation. Since my working diagnosis a year ago, I've come to realize that we are all part of this very large, complex jigsaw puzzle of pieces that we're trying to put together. So my question goes to the management of the data that underpins all of this. Because I'm actually a data scientist by practice, so that's where I'm coming from. So when I got my diagnosis, I did research on the online databases, and I found one other person has the exact same missense mutation in the exact same codon that I have. So my question is this, I don't know if you can speak to this. How do people reach out to one another? I found one other human being who has the exact same codon missense that I do. I don't know how to find this person, or alternatively, is there a body that's managing these connections and finding the patterns to connect people who have similar mutations? What is happening out there to pull the pieces of this jigsaw puzzle together?
Yeah. So we scientists, we don't have access to human data, but when we work with human samples, we don't even know what's their name, where they come from. To us, it's just a number. But that's why I think foundations are very important, because people become a member to the foundation, and then foundations may say, oh, I have this, 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 and then foundations may say, may I share your information with the other person? Maybe they will call you. Or maybe if this data was connected at an NIH site or in a governmental site, maybe you can connect those people, they would know, but it's not kosher for patients to find other patients and it's basically that data needs to be as sealed as possible for personal security.
Wonderful. We got one last question
Sure.
before we go.
And a simple question. What is the best way to contribute directly to your continuing NU9 research?
Come talk to me afterwards. And please, yes, definitely. I think these are very exciting times, and time is ticking, and I have never been more excited about research because we are at the cusp of something. And in NU9, with whatever experiment we do, there's not a single experiment so far that NU9 actually failed us. And Dr. Silverman is working with another colleague within the context of Alzheimer's and A-beta oligomerization. And it seems NU9 also reduces A-beta oligomerization. This may actually be a compound that reduces misfolded SOD1, TDP, and now A-beta. I mean, there may be actually an upstream mindset or big mind that controls protein accumulations, and NU9 could be one of those, and we don't know. And I am so excited. We are working day and night on NU9, and your help would be very much appreciated.
Thank you very much, Dr.
Thank you so
Ostenler.
much.
Great
Thank
questions. Great, everybody. Thank you very much.
And Dr. Ostenler will be around all weekend, so please feel free to approach her and have conversations throughout the whole weekend with her. And I think it's one of those things that's very important that you are a part of the foundation and understanding what is it that we're trying to do, and that is connect you guys and to connect like numbers and similarities. As you guys see from the name tags that you have, those kind of denote what gene mutation. So that's what we're here to help you guys do. So thank you all for your time.
All right. Okay, guys, just a simple couple of notes here. We're moving right along really well. Remember, lunch will be here in a little while in this room. That's always going to be a good thing. I also want to talk about some of our sponsors. We've had a lot of people that help us bring this event to you and get it's such a big program. We need a lot of sponsorship to help us. So we really want to say thank you to Chris Brocchini. She has been a huge supporter of the foundation for many, many, many years. And so we're really excited that she is still supporting us today. We like to say thank you to Matt Harden. We also like to say thank you to the Conlin Foundation, the Your Medical Store, which you guys are really going to dig. Saturday evening when we start doing auctioning and a bunch of other kind of fun stuff with that. You're going to like those guys. Cadence is here, and they're an exhibitor out front. We also have some anonymous donors who are anonymous, but we still love them, and they help us out, and we're really grateful for their efforts in taking care of us. Chick-fil-A, you guys saw those little cards in the front of the pouches of your thing? By the way, if you drop any of those, you're probably not going to get them back, because I know there's a lot of people that are going to like to get a handful of those guys, okay? We want to say thank you to Mary Kay Robinson, who helped putting together all the potato pants. She sewed those and made those for us for this event. That's really, really nice. So I just wanted to give a quick little shout out. I'll do some more a little bit later. We're taking a couple seconds. Remember, like Norma said, the doctors and the presenters are here in the building. They are amongst you. So feel free to talk with them over the next 36 hours or so. They're here. They like to talk. They like to tell you about what they're working on. It's really neat to have this really close partnership with the people providing the science to you. Outside of that, we are just going to keep moving right along. Coming up next, here we are. Dr. Fakari is our next presenter, and here he comes.
Hello again to our virtual listeners. We're glad that you're with us. And during this presentation over the next couple of days, I'm going to have a guest, Mr. James McLaren, who many of you know, Linda LaFontaine, who's very involved with the foundation. James is her husband. And he's going to work with us in between discussions to share a little bit of his insight on the research and information that we're hearing so that we might better understand that at home. So, James, any thoughts from what we've just heard?
So I just wanted to talk a little bit about a couple of concepts the doctor spoke of and make sure everybody kind of understands what's going on. So when we talk about dominant and recessive genes, everybody inherits two genes from each parent that kind of do the same thing. How does that work? Well, sometimes one of those genes is dominant over the other and the other one does nothing. Sometimes that doesn't occur. So for example, if you have brown eyes, you could have inherited one brown eye gene from one parent, one blue eye gene from the other parent. If you have blue eyes, the only way you can have blue eyes is if you have both copies of the blue eye gene. That's what she's talking about. Proteins, the genes are maps that make proteins. The proteins are like little machines inside the cell that do stuff, that act on various different molecules. And they kind of flex, they kind of move when they do that. They wear out, they get broken down with time. And there are proteins in the cell whose only job is to wipe out proteins on a regular basis, essentially as they get worn out. And that seems to be a big factor in HSP in particular, is these proteins that break down degraded proteins themselves are the ones that are defective. A protein landscape, like the genes make the proteins, each protein on its own doesn't necessarily do something. Sometimes they build a bigger conglomeration with other proteins and they sort of act together. And that's important because we have these many different mutations that seem to cause essentially the same disease in HSP. So it makes it hard to find a way to treat it, basically. And so Dr. Oz wants to understand how these things interact with each other so we can see what the problem is, basically. And when we talk about a druggable target, that's what kind of ties into that protein landscape. We want to figure out exactly what these proteins interact with so that we can find a drug that kind of fixes the problem. Just quickly, maybe mouse model and GFP. Mouse model is a mouse that exhibits the same mutation or a similar mutation. GFP is actually a molecule that causes a cell to glow in the dark, basically, so that you can see it. And it's a way to pick out a cell that has picked up a mutation versus another one that hasn't.
James, we're gonna pause now and head back to the stage. Dr. Fakhari is going to be talking to us, particularly about the work with the Spastic Paraplegia Foundation Centers of Excellence over the past year. James will be back with us, and we'll pick this discussion up again later. We'll turn to Dr. Fakhari and hear what he has to say.
Positive trend. There's still a huge gap between how much we know and how much we can translate into actual therapies, and this is for a number of reasons. So first of all, I think for one reason, we've learned a lot about rare diseases through genetics, and I think that's part of why this blue curve is really taking off. But at the same time, we're really limited by a couple of things. For many rare diseases, we lack appropriate disease models, we lack reagents, and on the clinical side, we often lack deep phenotypic and natural history data, and that has really held us back in many ways. But going forward, I think what we are starting to see is that there's change happening. And one driver of this change is the fact that we can diagnose genetic rare diseases earlier and earlier. And this is in part because next generation sequencing-based testing, so the latest generation of genetic testing, is becoming cheaper and cheaper and therefore much more available today and tomorrow than even just a year or two ago. Next slide, please. So the fundamental challenge that we face as a community, as scientists who work on rare diseases, is that we can identify the unmet clinical need, but there's a huge gap between the unmet clinical need and clinical care. And just to give you an idea of what the process of developing a therapy looks like, I'll show you this little schematic here, which, if you click one more time, shows you basically how we go from identifying a disease, starting all the way on the left with the phenotype, to getting a therapy approved and getting it to market. And I'm listing here the highlights of like every step of this pathway. And at every step, there's a unique challenge. So when we think about creating therapies, we have to think about where are the gaps in this pipeline? How do we bridge those gaps? And this is for every individual type of hereditary spastic paraplegia, there might be unique challenges, but this is the framework that we have to think in. And this is what our research is geared towards. So next slide, please. So our group really has taken on two areas. One, developing mechanism-based treatments. We define those as disease-modifying therapies that are targeted against a specific molecular structure implicated in disease pathogenesis. And we're modality agnostic. We work with small molecules, we work with gene therapy, we would work on ASOs or RNA interference if the right case arises. At the same time, we have to be ready for these therapies, and that's something that we look to establish through a program for clinical trial readiness. We define clinical trial readiness as a state of having validated clinical research tools to the point where you can design efficient clinical trials. And I'll come back to that at the end, why it's so important to be efficient in the clinical trials that we start. Next slide, please. So I'll show you some of the efforts towards clinical trial readiness. Next slide, please. One of the key pillars of our program is a large natural history study. This is something that started very small. It started in a clinic room with a single family 5 years ago. And we have since built this platform where we meet with families with children affected by hereditary spastic paraplegia and conduct a detailed assessment of clinical factors and biomarkers. And if you could play the videos, please, there are 4 videos. Just to illustrate you, one of the challenges that we face is that although we think of hereditary spastic paraplegia as one group of diseases, the symptoms across the age span and across different subtypes can look vastly different. So we had to adapt our study to that. You see at this point, this is data from the end of last year, we've seen just over 500 families in our program, and we've seen many, at this point over 100, for a second, third, or fourth visit. And this body of data really is informative because it helps us design clinical trials in the most efficient way for a given disease and a given age group. Next slide, please. Now, what have we learned? We can just click through the animations here and have all of them showed. So we've learned a number of things. We were able to make some contributions to the common autosomal dominant forms of hereditary spastic paraplegia. Here we really took on the challenge of interpreting de novo variants, and you'll hear more about this from my colleague, Dr. Luca Schierbaum, tomorrow when she's going to speak about the genetics of hereditary spastic paraplegia. Much of our work has focused on autosomal recessive types, which are more common in children, and we've made a number of contributions here. One challenge that we came across, and I think we've heard about this a little bit already, is that if you take 100 children with suspected hereditary spastic paraplegia and you apply the most advanced clinical testing you have available, you find a diagnosis in about 60 to 70%. So that means that 30 to 40 of these 100 children do not receive a genetic diagnosis despite the most advanced genetic testing that we have. So to close that gap, we launched an additional program called the HSP Genomic Sequencing Initiative, where we provide these families not just exome sequencing, which is now becoming standard of care, but genome sequencing and long-read sequencing, so the next generation of genetic testing to close that diagnostic gap, and you'll hear more about this tomorrow. Next slide, please. Beyond this, however, this is all important work. We all want to understand, the clinical phenotypes, the symptoms better, but at the end of the day, we want to develop therapies. And to me, this is a perfect platform for developing therapies because although hereditary spastic paraplegia is different between different subtypes and different age groups, there are some universal features, and we can leverage these clinical universal features, for instance, progressive lower limb spasticity, and really test different types of modalities using this platform. And if you look at HSP, you have all these different mechanisms represented, and you can start developing therapies based on the mechanism represented. And I'll show you an example of that later on. Next slide, please. So last year, this started at this meeting, actually, and we got together and we decided that beyond individual centers conducting natural history studies and trying to establish clinical trial readiness, we needed a network across the country because no single site can accommodate all the patients, can really do this efficiently. And to take us to the next level, we decided to start this clinical research network that we call the Spastic Paraplegia Centers of Excellence Research Network. And at this first round, there are 10 centers who are part of this and have agreed to become part of this clinical trial readiness platform, which will advance clinical trials, but will also advance clinical care. That's the hope over time. You see, we have some geographic representation in many parts of the country, not in all parts of the country, and that's something that we'll work towards in the second round. Next slide, please. So we set out to establish this network to really facilitate and achieve a number of things. First, we wanted to build key infrastructure, and this was much of what we did the first year. We wanted to define clinical outcome measures and biomarkers across the age span, so from young children all the way to adults. We wanted to help create a state-of-the-art genomics platform for cases that do not receive a genetic diagnosis. And then really the next step is to facilitate the testing of therapies in clinical trials. And of course, this extends beyond the United States. Hopefully we can sync up and collaborate with other consortia around the world because this is essential for rare diseases. Next slide, please. So we had, and we can click through all the animations, we had 3 aims here. So much of the first year was spent on aim 1 and aim 2 to organize the consortium, develop a central research protocol. We have enrolled the first patients at the Boston site, and the goal is to enroll 100 individuals in this pilot study with SPG4 and SPG5A in a shared clinical trial protocol. Next slide, please. This is just to show you, a few weeks ago we had the opportunity to enroll our first patient. This was a young boy with SPG4 who came to see us from Canada, and who's the first patient in this research network. So now I take a step back and I'll show you what we've done for one specific type of childhood onset hereditary spastic paraplegia, and this is AP4-related HSP. Next slide, please. This is a group of 4 different types of HSP, SPG47, SPG50, 51, and 52. Next slide, please. We can play these videos. This is just to illustrate that although these are 4 different types of HSP based on the gene mutation, these children have the same symptoms. So if we click through the videos, you see that despite the fact that they have different mutations and different genes, they all share similarities. They all present with delayed development, initially with low muscle tone, and then over time with progression to spastic paraplegia. Next slide, please. So this was work that we conducted now a number of years ago, looking at the first 150 patients that we met from around the world. And we identified something that is very common, and I'm sure many in the room can relate to, which is that despite the fact that symptoms started in this specific type of hereditary spastic paraplegia, the first year of life, the average age at a genetic diagnosis was 10 years. So there's a huge diagnostic delay. This has changed in recent years. Most of the children that we diagnose now are younger. They're 2, 3, 4, or 5. But I still think that this is a problem around the country, and I think something that we look to work on in the next years. Next slide, please. The hallmark feature of this disease, not surprisingly, is progressive spasticity. There's a sequence from neonatal hypotonia, as I said, low muscle tone initially, then to spasticity. And unfortunately, from this cross-sectional data, we know that this is a progressive presentation, and a subset of children and young adults with this condition do have involvement of their arms, for example. Next slide, please. We can play through all these videos. I'm just trying to make the point here that although we've had a chance to meet so many families from around the world with this rare condition, it really gave us a couple of challenges. And mainly the main challenge, I think, is that the symptoms do have a spectrum. There's a spectrum from mild to severe, and there's also the factor of time and development. So studying this in children is much more challenging because this disease, unfortunately, unfolds at a time where these children are developing and learning new things, and so it makes it very hard to measure things. Next slide, please. One approach that we've taken is to do a very detailed characterization, not only of clinical factors, but also MRI images. We identified a signature of this disease that can now help diagnose this condition even without genetic testing. Next slide, please. And these are the most common symptoms. So even from this first cross-sectional analysis, we were able to learn about the disease spectrum and define the disease spectrum. But that's just the first step. This allowed us to then design longitudinal natural history studies to look at the changes over time. Next slide, please. And one thing that we've learned, and I think this is something that is pertinent to all childhood onset forms of hereditary spastic paraplegia, is that this is likely both a neurodevelopmental and a progressive neurological disorder. There are clear signs that there's involvement of early brain development, but then there's a second phase of the disease where we see progressive disability occurring, progressive symptoms occurring. Next slide, please. We're starting to understand in natural history. These are just some examples. You don't have to understand the details of this graph. The point is here, we're measuring development. And what you can see here basically is that development over time plateaus in these children as they sort of reach their capacity in different domains of development. Next slide, please. We see that motor disability, this is the spastic paraplegia rating scale scores, increases with age as a surrogate for disease duration. Next slide, please. And we find that, and this is something that I think is very important and something where we rely very much on the patient community. Through patient-reported outcome measures or caregiver-reported outcome measures, we're able to establish which symptoms are actually relevant to families, which symptoms are actually relevant to patients. And that's important not just for us as clinicians, but it's also important for conversations with the FDA because, of course, anything that we propose as an outcome measure has to be relevant to the patient and the family. So we've taken this very seriously, and in SP-CERN we have a whole battery of questionnaires that are targeted at understanding quality of life and daily activities. Next slide, please. Of course, all these clinical outcome measures are great, but what we really need is a biomarker that we can measure, something as simple as a blood test. And we've looked at a number of things. This is an example of a marker called neurofilament light chain, again in patients with AP4-related HSP. And we found that on a cohort level, the levels were increased, but we don't know yet if they're increased in a longitudinal fashion, if they're a true disease marker over time. Next slide, please. Okay. So I've shown you a couple of examples of how we understand hereditary spastic paraplegia and build tools to conduct clinical trials. And now I want to switch gears and talk about therapies. And next slide, please. This is a very busy slide, but I want you to take away basically one thing, which is that there are disease-modifying treatments. Those are the types of treatments that get to the problem, the molecular problem in the cell. There are symptomatic treatments. Those are the types of treatments that we already have available that treat the symptom, but do not affect the underlying molecular problem. And it's very important to think in these two categories. And really what we want to see happening in the next year is that we shift from treating the symptoms to treating the underlying disease process. And this is not for HSP alone. This is for all sort of movement disorders that we see in our program. There are a lot of efforts in that direction, and that make me very optimistic that we'll see many of these disease-modifying therapies come to HSP. Next slide, please. So if you want to think about this systematically, you go back to the drawing board and you ask yourself, what's the molecular mechanism at play in a given form of HSP? And depending on these, and this is obviously a simple sketch and a simple representation in a review paper, but based on these four big categories, you can start thinking about what treatment modality is the right one for this type of HSP. Is it a loss of function? Is it a gain of function? Is it haploinsufficiency? Is there a specific type of variant that could be amenable to antisense oligonucleotides, for example? Next slide, please. So we can just go through these. I'm just, in preparation for this talk, I looked, and I looked on clinicaltrials.gov to see how many clinical trials are happening in North America for hereditary spastic paraplegia. Not just symptomatic treatment, but disease-modifying. There's one for SPG50 right now, so we need to change that. On an optimistic note, I think there are a lot of preclinical efforts that will hopefully come to a clinical stage, and I'm listing a couple here. So focusing on small molecule drugs, there are specific small molecules that are coming towards specific types of HSP. There's a number of gene therapy programs that I know of because we're involved in it, but there might be others that are at a preclinical stage. And now really is the time to think about how do we get from preclinical to clinical for these specific types of therapies. Next slide. Next slide. So I'll come back to AP4 HSP because this is an example of how we go from preclinical to clinical. When we started working on this some 6 years ago, we knew what the gene was, but we had very little understanding of what was happening downstream of the gene mutation. And next slide, please. We worked very hard to understand the biology to the degree where we could use the biology to develop therapies. And this is just a summary slide to show you that work over the last 6 years has delineated some of the downstream pathways of AP4 deficiency. Next slide, please. Without going into very much detail about the biology, one thing that we leveraged here was the fact that AP4 deficiency leads to a mislocalization of other proteins. And one of those proteins is called ATG9A. And without knowing anything about the biology of this protein or this disease, you can tell that the cell on the left looks different from the cell on the right. You see a lot more dark signal around that light nucleus on the right. And this is a difference that we saw in every model of AP4 deficiency in every patient-derived cell. And again, knowing that this is an immediate downstream effect of AP4 deficiency, we were able to leverage this cellular phenotype to develop high-throughput screens. You'll see that on the next slide. So we can click through this. Basically, we had this phenotype and we said, okay, how can we leverage this for therapy development? We set out to do small molecule screens. We've done a number of functional genomic screens that I won't talk about today. But really, this is to get to a therapeutic target based on a simple cellular phenotype. Next slide, please. This slide shows you basically the workflow, summarizing several years of assay development, really. But basically, now that we understand this mislocalized protein and can measure it on the level of individual cells in formats that are amenable for high throughput screening, we can start screening for molecules. This is very much what Big Pharma does. They basically develop assays and then run these large unbiased screens to find molecules that can correct the phenotype. And you see in this example 384 well plate that you can identify outliers very quickly based on your pre-specified metrics and then look more into the molecules that have provided a rescue. Next slide, please. This is again summarizing years of work, but basically, in one of those screens, we teamed up with a pharma company called Astellas. They provided us with a library of about 29,000 small molecule compounds that we screened. In this primary screen, we identified 442 that were active, that corrected the cellular phenotype. Next slide, please. I'll summarize, and this is published now, all the stages that we went through after: secondary screens, orthogonal screens, validation in patient-derived iPS cell-derived neurons, which are the closest surrogate to a neuronal model derived from a patient. And through this, identified a set of lead compounds, and one compound in particular that we think has favorable properties. And this program is now at the stage where we've synthesized the compounds, analogs, we've tested them, and now we're testing them in vivo, in a mouse model, to see if we can correct phenotypes not just in a dish, but also in a mouse. Next slide, please. So I said in the beginning, our team is agnostic to what type of therapy we work on. We want to test whatever works the best for a given disease and a given patient. And as I've introduced earlier, this is a loss of function disease. So, from this, it follows that the best and most proximal approach to treating this disease is to replace the gene that is defective or missing. That's what gene therapy is. So, some 6 years ago, we teamed up as part of a larger consortium to develop a gene therapy for APOE4-related HSP. Next slide, please. One of the programs that is now in a clinical trial with 4 children treated thus far is for SPG50. I won't go through all the data, but just to illustrate the concept. This was, 4.5 years ago, was just a sketch on paper. We knew, and this is mainly work done by Stephen Gray at UT Southwestern, we knew how a gene therapy could look like, building on experience from spinal muscular atrophy and other diseases, and designed this gene therapy vector specifically for SPG50. We and others tested this vector in patient-derived cells, found that the vector was able to correct the underlying phenotype in the cells, then moved, next slide, into mouse models, and were able to show that in the mouse model, which hadn't been created at the time, created in parallel, this gene therapy vector corrected some of the phenotypes. This gave us enough confidence to move into IND-enabling studies. Next slide. And this involved toxicology studies, as is commonly required for gene therapies in mice and rats, and in this case also non-human primates, which allowed us to identify the safe dose and helped us design the clinical trial. Next slide. And we can click through all of this. This is just an example. I'm not going into the sort of the details of the science here, but just to show you that you can go from concept to proof of concept to a clinical trial, even for an ultra-rare disease, if you have the right collaboration, the right support. So all of this was made possible by incredible fundraising and philanthropy by patient advocacy organizations. It was supported by the platform that we had built for natural history and biomarkers. It was supported by the therapeutic entities that were developed at the University of Texas Southwestern and the University of Sheffield for a second program for SPG47. Then we had enough funds to really conduct proof of concept studies in different laboratories independent of each other. They gave us confidence to move into the very expensive parts of this, which are toxicology studies and manufacturing. And then for SPG50, this is in a phase 1, phase 2 study, 4 children treated thus far. We're planning a phase 3 study. So if you remember the cartoon I showed in the beginning, there's a part that goes towards approval and market access. You need a phase 3 study to get there. So we're designing this, and this is unique. I think it's never been done for a disease so rare. And at the same time, we're learning from this first clinical trial, and we look to repeat it for the next disease, which is SPG47, and hopefully for others in the future. So just to show you that you can go from concept to proof of concept to a clinical trial. Next slide, please. So with this, I'm at the end. We can click through all of these. I hope I was able to show you that there are unique challenges, but also opportunities for creating therapies in rare diseases, including childhood onset HSP. I think at the foundation, there's access to genetic testing and longitudinal natural history studies to really establish clinical trial readiness. I've showed you AP4-related HSP as an example of both a neurodevelopmental and neurodegenerative disease. I've shown you how we develop small molecule treatments through high throughput screens in a lab. And I've shown you an example of a gene therapy that made it all the way from concept to a clinical trial. Next slide, please. So with this, at the end, I have to thank the many, many, many people involved in this work, but most importantly, patients, their parents, their families, and advocates who support all of this research and come and see us in Boston, support our research studies, and all the funding agencies, including the Spastic Paraplegia Foundation, which have made this possible, which have made the Spastic Paraplegia Centers of Excellence Research Network possible, and hopefully we'll see a lot more of these therapies coming to a clinical stage. Next slide, please. So these are the studies that are open for enrollment right now. If you're interested, please reach out to us. We're very happy to tell you more about the work that is ongoing. So thank you very much for your attention.
Hi, Dr. Darius. Thank you for your presentation.
Of course.
Can you tell those of us with children with HSP if your work with the AP4 work will carry over to the other subtypes?
Yeah. So in terms of gene therapies, those are disease specific. Those are specific to a specific gene, which is a major challenge because basically you have to develop a different vector for every disease. There are some elements that you can take over, but at the end of the day, you have to develop 80 or 90 different gene therapies for 80 or 90 different diseases, and that's a huge financial challenge. This was one of the reasons why we started the small molecule program, because we realized that even developing 4 gene therapies was going to be very challenging for financial reasons. As far as we can tell, the small molecule treatment that we found only works for AP4 deficiency. It does not carry over to other types because the molecular problem is different.
Good. Thank you.
Yeah.
Any other questions? Anybody? Here's one over here. I'm going to go over this way.
Very good talk. I appreciate all the information. This is kind of a multi-part question. I don't have HSP, but still some of the work that you guys do in motor neuron disease helps all of us. When you talk about gene therapy, the number to treat is so small. You mentioned specifically like SPG50, you mentioned 4 patients.
Yes.
If you were trying to scale that to get an approval for gene therapy, I want to know how would you do that? And is there a pathway or conversations that you guys have had with the FDA to even do that? Not just for that, but it would be for any disease, if that makes sense.
Yes, absolutely.
And do you share your research with, do you have another Fakari in Europe or Asia or somewhere to where you guys might be able to raise awareness or get more patients into clinical trials? Thank you.
Those are 2 very insightful, brilliant questions. So I'll start with the first one, scalability of this approach. Major challenge. Major challenge for any gene therapy in rare diseases. There's a unique circumstance here, and the FDA appreciates that in the conversations that we had with them and in designing the phase 3 trial, which is that typically in a phase 3 design, you need a placebo-controlled group, which is challenging for a number of reasons in rare diseases. In AP4-related HSP, we've been able to show that the natural history of all 4 subtypes is the same. So what we propose is, in a way, a platform approach where you have a central control group recruited, matched based on the patients that are in the treatment arm, for those subtypes where a gene therapy is not accessible yet. They will serve as the control group for all the types where a gene therapy will become accessible. So it's a long shot, but we're hoping to, even with a small number of patients in the phase 3 trial, to be able to show efficacy and then move to approval. As I said, this is the first time that anybody has tried this, but it's a unique circumstance for the reason I mentioned, that you can have a control group without the ethical or recruitment issues that you typically have in rare diseases. Second question about international collaboration, absolutely. This is one of the reasons why we decided to get organized in North America and in the US, because there are similar networks in parts of Europe, in Canada, in Japan, and Australia. So we've already had a lot of traction and conversation with those partners, including in Germany and South Korea. And really the goal is to synchronize this as much as possible so that we're all conducting studies in the same way and can learn from it the same way. So absolutely, it's one of the big motivations to pursue this network. Yeah.
Okay, Dr. Fakar, we have a question straight up center ice.
I'm at the opposite end of the people that you're working with in terms of the disease. And I'm also one of the 35% of people that do not have a gene associated.
Okay.
And I've gone through at least the NIH screening, and then I went through screening with Invitae last year. And all, I'm still, as my purple thing says, I'm unidentified. So, and I sort of feel a little lost because I'm unidentified.
Yes.
Yet I've not heard anything that makes it really important other than for the whole community to go further. And I'd like to get your thoughts about, because I don't think it's going to affect me, but will it affect my children, others, the whole research area? How far should the average person with unidentified HSP go to, in terms of all the different variations that are relatively expensive, but are they important for the whole community to be able to have that information?
Thank you for that question. It's a brilliant question, one that is very, very relevant, I think. The short answer is yes, we should try. We should make every effort to identify a genetic diagnosis. The reason is that this is an entry point. It's an entry point for a lot of things. One, it's an entry point to a specific community. Two, it's an entry point into research. Three, it's an entry point, if it's a known gene, to specific counseling, anticipatory guidance, genetic counseling when it comes to the family and children. So absolutely. This is a rapidly moving field. The things that we talk about in terms of genetic testing today didn't even exist 2 years ago. So I'll encourage you to connect with our team. We can direct you to similar efforts for adult.
Because the reason I'm asking the question, there are companies out there,
Yeah.
and it's very hard for the consumer
Yes.
to be able to judge A, B, or C, which is the best way to approach that question.
Yeah, so I think this goes beyond clinical testing you would do with a company. So there are a number of research studies for HSP that are looking to apply research-based genomic testing, and we can certainly do this for any individual under the age of 30, but we have partners at the University of Miami who cover the whole age range. There's a program at the NIH, there's the Undiagnosed Disease Network at the NIH. So there are these 4 resources, at least from the top of my head, that I would recommend. And this goes beyond anything you would do with a company.
Right, okay, so I'll send you an email. I think
Absolutely, and Dr. Schierbaum from our team will speak about what we do tomorrow, I think, so that'll be a good opportunity.
Okay, great, thank you.
Thank you.
Okay, Dr. Fakar, you almost got a question in the far right corner.
Hi, thank you so much for all your information. I have a question, but it's not about the research. With working with children with SPG4, have you found that in almost all cases that children who are starting to show signs of the disease have delays or show developmental delay early on? Or can they be completely, I don't want to say the word normal, and then start showing signs? Do you always almost see the developmental delay?
It's a great question, and I would say both is possible. So the short answer is more often than not, we see at least subtle signs of motor delay. But we've also certainly met families where there were no signs of early delays, early motor delays, and the onset was later. So I think there is a little bit of a spectrum. We have certainly learned that children who have de novo mutations, for reasons we don't understand, typically present earlier. but both scenarios are possible. In the familial form, the second scenario of maybe only mild delays or no delays is more common than in the de novo form. Yeah.
Hey, do we have any more questions? I see one. Norma, your side of the room is, come on, girl, all the way up in the front. Keep coming. Okay.
I have a couple of questions.
Yes.
I'm new to all this, so the part about where you said like the treatments are, treating the symptoms, and then you've got the underlying treatments. Underlying treatments, I'm assuming, is like the gene therapy. And the systematic treatments would be, like you've got baclofen, or you've got physical therapy, you've got different things to treat speech or the behaviors.
Exactly.
My question is, can you explain? What? And I have another question after this, but what gene therapy really is? Like, what does that actually mean for gene therapy? Because the other stuff I understand, the physical therapies and all those things,
Yes.
but what is gene therapy?
Very, very happy to. So when I use the term gene therapy, really what I refer to as gene replacement therapy. So very simply put, this is a way of replacing a normal copy of the mutated or missing gene through different so-called vectors. And most of these vectors are particles derived from viruses. So the best example I could point you to is the gene therapy for spinal muscular atrophy. But in essence, it's a technology where we use viral vectors to deliver a healthy copy of the gene.
Oh, okay. And then also, when you said, I think it was the SPG, or the 4 is the one you're working on, it had the neurodevelopmental disorder and the neurodegenerative disorders are connected with that one. How do we find out for our specific, is there a way to find out if our children who have a different HSP have that? Do you know what I mean? Because I'm looking at the definitions. What does that really mean? And those words, what does that mean? How do we find out if those are the things that are connected with our gene?
Yeah, it's a great question. I think we learned about this through examining a larger number of patients. So there are specific things where we can definitively say this is neurodevelopmental. I'll give you an example. When we looked very carefully at the prenatal ultrasounds that were done as part of routine prenatal care, we identified that in a number of patients you could already see certain structures of the brain not having fully developed. And that's clearly developmental. It's not something degenerative. So that's an example of a symptom or a presentation that probably dates back to the very early brain development. And so the short answer is, I guess, is that you have to look at a lot of patients very carefully to identify which symptoms are related to changes in neurodevelopment and brain development, and which changes are truly a surrogate for a progressive process.
And that clinical trial that you're doing, the registry one, is that to connect people, like also who have the different HSPs? Will it connect people together?
So we
families?
always make that effort because we realize that many of the forms of childhood onset HSP are so rare, and it's a very, very lonely place to be in. So if there's mutual permission, we always try to connect families, yes.
Dr. Fakari, right here.
Yeah.
Just a quick question about that study, the natural history study. It's for patients with a childhood onset. So if we have an adult child, my son is 26 now, but he did have a childhood onset. Do you still want those patients involved in the study?
Thank you for that question. We do enroll patients up to the age of 30.
Okay,
that has logistical reasons, but 30 is our cutoff.
Okay, thank you.
Okay, Dr. Fakari, I got another one on your far right. You got other way. Oh, way over here.
Hi, good morning, Darius.
Good morning, Oscar.
I have a question about gene therapies. I've talked to some leading gene therapy companies here in the States, and we're interested in that too. And the data you show for AP4 is brilliant. But the animal studies are really, most of the animal studies are done on mice.
Yes.
And then the mouse brain is really different from the human ones.
Yes.
So a lot of companies have concern about distribution of the viruses. Maybe you touched on it. Like, I don't know, for the clinical trials, what are they using? As in terms of a capsid of the virus, or what's the volume of the virus they're using in the human trial? Are they doing intrathecal, or are they, what are the strategies that cover that kind of concern?
Yeah, you bring up a very, very good point, and I completely agree. I think biodistribution is a major challenge for central nervous system diseases and the current generation of vectors. I think the first step is to identify what is your target tissue. And without really having a lot of proof for that, for HSP we say you need at least the cortical spinal tracts, because we know that's the structure in the brain that, if affected, can give rise to spasticity. Okay, that's an assumption we make. We have no proof of that. So then you target your tissue, and then you have different capsids available. The capsid we're using here is AV9, and that's just simply for the reason that there's an established pathway with spinal muscular atrophy. The route of administration for SPG50, for the SPG50 trial, is lumbar intrathecal. So it's a single lumbar infusion. And building on the experience from another clinical trial, the giant axonal neuropathy trial at the NIH, we know that biodistribution, this is published now in the New England Journal earlier this year, we know that the distribution is pretty good in the spinal cord. It's good in certain parts of the brain, but we really don't get the deeper brain structures. And that's a major problem. So for the second trial, we're already switching the route of administration. So we go from lumbar intrathecal to intracisterna magna. Will this be the best way to do it? I don't know. And the challenging part, and you brought up the mouse model, is that really none of the preclinical models predict that. We have to do the clinical trial to learn that.
Right, thank you.
Hello, Dr. This is Shamal Shah. My daughter does have a de novo mutation. She's a 13-year-old right now. We had seen the symptoms since probably 3 years old she was, 2.5, 3. She's around 5.5 actually. It was Dr. Blackstone's research that found the mutation. She has SPG3A ATL1 mutation. My question is, hearing a lot around the gene therapy and what we are reading as well around that, one of the concerns we have had over the years has been just the scalability of the treatment path. Most of the readings has been around very targeted, approach towards it, given the spectrum that's very broad in this disease.
Yeah.
What's your kind of thought around progress that we can expect over the next 5 to 10 years in this direction as well?
Yeah.
Given the doors it opens up, but some of the scalability challenges that exist.
I think the scalability issue is real. It's certainly real also for SPG3A. I think we need to have some successes. This is what happened with spinal muscular atrophy. I think the same conversations were happening before the gene therapy was successful. And if we see a success, that will, incentivize and de-risk the development of these kind of therapies. I think the challenges are real. Don't get me wrong. I think getting a gene therapy approved for a rare disease as rare as this is a huge challenge. But I think we have to, work in that direction, hopefully see some success, which will incentivize new programs.
Okay, everybody, that sounds really, really great. Great questions, great answers, of course. Great science, it's wonderful.
And Dr. Fakari will be here, so you guys have a chance to talk with him and his staff. Where is Amy and Dr. Luca? They're back here, so there's plenty of time to talk with them, so make sure you do that.
Okay, everybody, this is your lucky day because we have a little bit of a break right now, so you guys can stretch. I always say we're going to give you a 5-minute potty break, which really translates into about 3 hours. We know how it works, at least at my house, that's how it goes. So we're going to give you a little bit of a break because we've got some exercising and some stretching and some really great stuff coming up at the top of the hour. So guys, take a stretch, get your muscles warmed up, and we'll see you back here in just a little while, okay? Thanks, everybody. And real quick, while you're out there, make sure you guys go to the merch table and buy those raffle tickets. There's a lot of great stuff out there. Go out there, check it out, open those wallets, have some fun, You never know. You never know. You can't win if you don't play.
Hello again. You've heard some great speakers this morning. You hear Dr. Osdendler talk about how important the research is that she's doing, and particularly with NU9. She's talked about how time and money are so important, so contributions that go toward that work are extremely important toward moving toward clinical trials that can make a difference. And then Dr. Fakari with his discussion about all that he's working on. He's the leader of our Centers for Excellence and Research Network. So a lot of exciting things going on there, and we want you all to know all about those things. But with me right now is it has been so exciting. We just met Dr. Lauren Leyva this week. She is with Exerscience, and she's going to tell you in just a moment what that's all about. But you're going to be seeing her in the next session kind of talking to our membership about how important it is to move, how important it is to be thinking correctly, and moving yourself in a direction that can keep you healthy and on the move as best possible. So, Lauren, I'm going to call you Lauren. You're my friend. It's great to meet you. Great to see you. Share with our visitors what you do and what you'll be doing with us here this weekend.
Thank you for having me. So I'm Dr. Lauren Leyva, owner and founder of the Exerscience Center in Tampa, Florida, and maybe soon in your area. I heard what you said. Another speaker talked about time and money. And for me, I know time is the most valuable resource on this planet. I think even way more than money. My mother's no longer here, and she always told me you can't take it to the grave with you, right? So each moment on this earth is just a blessing for me. That's my perspective. And that's how I built my clinic, is to achieve results faster than traditional therapy. So it's a biohacking neuromuscular wellness clinic. And I think when you came in, you could see it's very different than most clinics. I was in an electric suit, shopping around for the best technology. And that is also what is a little different about my center. I think that many clinics will get into a perfect wheel that they really enjoy, they can implement really well. But just like our iPhones, everything is updating consistently. So my clinic is based on learning something new every day and being on the edge of medicine with modern technology, but not forgetting traditional medicine, ancient wisdom and practices, respecting everybody's values. So that's how I built my center.
Dr. Leyva, as we think about what you'll be sharing here with this group today, we're talking with folks at home who are with us by virtual feed. If you could tell them right now one thing that they ought to do today and make a daily commitment to doing to maintain their lives, their physical circumstances, and enjoy life to the very fullest, what one thing would you tell us all to do?
Well, because I'm a little bit of a joker. I know you met me. I'm gonna say a little bit of a joke while I tell you, but I would say squeeze your butt. So squeeze your butt and think about something you love. But when you squeeze your pelvic floor and your muscles, whether you are bed-bound, wheelchair-bound, or you walk, often we might sit for more than 20 minutes. And again, even more so, this population, if you are wheelchair-bound or bed-bound, sometimes you might not get a lot of activity down there. And even if you think you can't, I used to have a colostomy bag, and the doctors told me I will never go to the bathroom normal again. And I don't have a colostomy bag anymore. I do go to the bathroom normal, and I don't let other people define me. So that's what I would say most. Don't let others define you. And I know I didn't answer it the best, but I would say squeeze your butt and think of something you love.
Well, that's pretty simple, and that's really easy to remember.
Yeah.
And we want to thank our Florida group down here as we worked on this conference for the past year. They helped in so many ways, and And as Norma reached out trying to find local businesses, local people that would have an interest in working with us and supporting the work in this conference, Dr. Leyva, you stepped up, and as soon as we met you and began to talk with you, we appreciate your genuine interest. We know you have a business, and we know you run that on a daily basis, but when we stepped into your clinic a couple of days ago, you're right, it was a very different kind of clinic. Seeing some of the machinery and some of the technology that was there to help analyze what might be wrong or systematically need to be improved within a person was very interesting. And so we appreciate with your busy life and busy schedule, you're taking the time to work with us in this foundation and in this conference. And we look forward to what you have to say to these folks out here. And I'm hoping as you talk to them in a few minutes that we see them moving a little bit, stretching a little bit. And thinking more about how we can be a little more mobile and a little more active, both mentally and physically.
And if you see their heads going up just an inch, you know what they're doing.
Well, thank you, Dr. Leyva. We appreciate you, and we look forward to working through this weekend with you. And folks, in just a few minutes, she'll be speaking to this group, and we'll learn a lot more. So thank you so much for being with us.
Thanks so much. And if you're online, you can follow me at theexersciencecenter.com or Queen of Biohacking.
Great. Thank you again. And I want to take just a few minutes to thank all of our sponsors. And they're all in the program, and I know you guys can look at them, but I want to take a moment while we have a break just to mention them specifically. Chris Brocchini, who has been a major sponsor of this conference for a number of years, and she normally tries to be with us, but she couldn't be here. And we want to say thank you, Chris, and we miss you, and hope all is well with you. Matt Harden, Conlin Foundation, your medical store, Cadence, who's a shoe exhibitor outside, and it's exciting for those of us who have difficulty walking, seeing their product, and we'll be interviewing them so you can learn more about that a little bit later. Joshua Cochran, Toby and Becky, the Cochran family. We've had a number of anonymous donors, the folks who are here, the bags that they're carrying, which are very nice bags, were contributed by an anonymous donor. And so we thank our anonymous donors. Mary Kay, Chick-fil-A, the Karen Gerlasio, Captain Cookie Beads, First Community Bank of the Heartland, the Tampa Bay Rays, U.S. Youth Soccer, Canine Companions, and Glow Natural Wellness are the sponsors who have helped us here put this conference on. And Dr. Lauren and Exercise, we appreciate what you guys are doing to help us with this conference as well. So we're going to take a break for a few moments. We'll be back with you for some exciting time with Dr. Lauren. So take a break, and we'll see you in just a few minutes.
Bye.